Hello, this is Chris O'Flaherty with Oculus, and on behalf of Oculus, I'd like to thank you for attending tonight's webinar, Advances in Corneal Collagen Crosslinking in the OCULUS Pentacam. If you have any questions during the webinar, feel free to enter those questions in the text box on the right of the screen. Our speaker this evening is Dr. William Trattler. Dr. Trattler is a board-certified ophthalmologist practicing in Miami, Florida at the Center for Excellence in Eye Care, where he performs a variety of cataract and refractive surgeries. Dr. Trattler has been an investigator for several next-generation technologies in ophthalmology, including the topic for this evening, corneal crosslinking. And here at Oculus, we're certainly excited to have Dr. Trattler tonight share his experiences with us. So without further delay, I'd like to welcome Dr. William Trattler.
Chris, thank you so much, and thank you everyone for spending some time with me today to talk about corneal collagen crosslinking and diagnostics that we can use to analyze patients before and after the procedure. So I'm William Trattler, of course. I'm in practice in Miami, Florida. I do have a financial interest in a company called CXLO, which hopefully someday will get some technology approved for corneal collagen crosslinking. I'm also a speaker for Oculus. So tonight we're going to talk about the Pentacam, as a diagnostic tool for patients with keratoconus, post-cystic ectasia, and occlusive marginal degeneration. And I find this technology very useful for my patients because I have patients that come to see me with a ectatic cornea, and we want to figure out, first of all, whether patients are getting worse over time before crosslinking, and then after we crosslink them, are they getting better? And the technology or the tool that I use is the Pentacam difference maps. You can see here, this is an example of a patient where we had a patient who came and had their treatment on November 11th, 2013, and they came back in 2014, about 7 months later. You can see the difference, which is A minus B, in the far right-hand corner. So you can see the dates are up in the top, and then we can look at a very important parameter, which is the Kmax. You can see that the Kmax flattened over this time period by 2.5 diopters, which is quite a bit. We'll talk about some data on what to expect with crosslinking, but this is some nice flattening. But the 2.5 diopters itself is a number, but doesn't really show us what happened. What we want to look at is the difference map. You can see that where the cornea was steepest, and actually where it was also the thinnest, where there's this little white triangle, which I'm kind of using my pointer to point to, that area flattened, and you can see that in the difference map where it's all blue. So the bottom part, the steeper part, got flatter. And we also want the flatter part preoperatively, which is above, to get a little steeper. And you can see that's represented in green in the difference map. So really, this difference map is so helpful because it tells us that the bottom part of the cornea got flatter, the top part of the cornea got steeper, so the general shape improved. And so this patient, as expected, also did better vision-wise as well. You can see that difference there was 4 diopters. Now, I do have a placido disc topography unit in my office, and this is the technology we're using. It's called Magellan. It's a great technology, but it doesn't really work well for patients with steep corneas. Here's just a patient with a Kmax of 97.6, and it is a very steep cornea, and you can see that it really could not image this cornea. So the placido discs, such as there's all different technologies, just really aren't useful for more advanced keratoconus as compared to a shine fluke technology like the Pentacam. And it's just a comparison of the same patient, and you can see the difference between the two eyes that the Pentacam could evaluate the patient, and so we could use it as a starting point or to look at differences over time, while the placido disc is really not that helpful. Now, I thought I'd start off with a very nice young patient, a 10-year-old male, who came into me in January 2014 for a possibility of crosslinking. And we talked about it with the family, and they were very excited to move forward with crosslinking. But obviously it was January 21st, and he was in school, so they decided that they would wait for spring break, which is in March. And we talked about the risk for progression. It's always hard to know, but I just want to share with you this patient. You can see the significant change over time. So beforehand, let me go back. This is the initial visit. You see the Kmax was 58.7, and the thickness was 521 at the thinnest point. So you can get a thinnest location thickness number. And you can see when the patient returned, the Kmax had increased to 63, and the cornea had thinned because the patient had bulge over those 3 months. So unfortunately, over these 3 months, there's significant progression. And so I do try to tell my patients in general to act fast when we diagnose them, but here this is an obvious situation where even faster would have been helpful. 3 months was too long for this patient. Now, so that was a young patient. What about older patients? And the question comes up, well, once patients are in their 30s or 40s, maybe they're pretty stable, you don't have to worry about progression. But actually that's not the case. And I do see lots of progression in patients over the age of 40. And here's an example of a patient. This is a patient who's 63, and over 4 years had significant progression of the keratoconus. They increased from 59.4 Kmax to 63.8. And exceeds a 4.4 diopter difference over time. Here's a patient, 52-year-old female with keratoconus, and this is progression over 3 years. They went from 49.8 to 59.1, so a 9.4 difference. It was unfortunate the patient did not come back and see me in between. I would have been happy to have recommended cross-linking. We did talk about it back in 2011, but the patient, maybe I never tell patients that they could be stable, but you can see this patient had significant worsening of their disease, and if we would have cross-linked this patient in 2011, the patient would be much, much better. So just waiting for progression means that you're waiting for them to get worse. And just as with glaucoma, we don't want to wait for patients to get worse. We'd rather stabilize their condition early. What about intacs? Can intacs stop progression of keratoconus? So this is just a photo of a patient with intacs. You can see this is a patient example from 2012 to 2014. So this is 27 months. You can see this patient had significant progression of 2.8 diopters of their Kmax over 27 months. So again, this is a patient, he's in his 40s. Sorry, the age is not there. I'm pretty sure he's in his 40s. So I know him personally. You can see that there's significant progression over this time period. So, patients with intacs who have not had cross-linking can benefit from cross-linking to stabilize the cornea. So how do we evaluate patients with keratoconus to see if they progress or if they have improvement? So I like to look at really 3 parameters. I like to look at the best corrected visual acuity changes, the uncorrected visual acuity changes, and the Kmax changes. These are 3 useful quantitative numbers we can look at. I do think that the difference maps provide the most information, but it's hard to quantify difference maps. So these are at least 3 different parameters that we use in our outcome analysis. Now, in regards to diagnosing keratoconus, this is also another very common situation is patients come in and we try to determine, does this patient have early keratoconus and are they a candidate for laser refractive surgery? So when I see this type of patient, I can use the Pentacam in a variety of different ways to see if it helps. So as you can see here in the top left corner, that's called the sagittal curvature. You see that there's the area of green is much wider below and actually gets into the yellow region. If you look at the numbers, there's about a 3 diopter difference from top to bottom. So this has some inferior steepening. We don't have an IS ratio, but you can see this patient does have, generalized steepening below. And there's also, thankfully, this patient does not have any skewing of their axis. But then we can also look at the lower right-hand corner in this particular map that shows the elevation of the back surface of the cornea. You can see that there's also some thinning and bulging forward inferiorly. And you see that's where this orange and yellow area is. So this does look like there's actually some, some protrusion internally, suggesting that this patient may have some early keratoconus, and it corresponds to where the cornea is steepest. And just showing you in higher magnification the 2 sections. And you can see again the inferior steepening in the left and the bulging forward of the posterior elevation in the back. And if you look at the thinnest spot, instead of it being centrally or near the center, the thinnest spot's actually displaced inferiorly, another sign suggestive of early keratoconus. I also like this map called the potential thickness increase map, and you can see this is a very useful map because it looks at the thickness change from the center at 0 all the way out to the peripheral part of the cornea at 10 millimeters, and looks at the change over time compared to age-matched controls. Normally the cornea is thinner in the center of the cornea and gets thicker as we get towards the limbus. And in patients with keratoconus, the center cornea is abnormally thin, so the rate of change of thinness to thickness from the center to the periphery is more exaggerated, it is more rapid. You see that this patient has this red line falling off, and the change is more rapid than what's typical for the patient's control group. So this is just a useful test that I also use to help evaluate my patients. Now let's talk about crosslinking. What is the role of crosslinking? Well, obviously we all feel that it's meant to stop the progression of keratoconus, but I think that that's one of the misconceptions of crosslinking, because crosslinking is more than just stopping progression. We often typically see improvement in corneal shape. We often see improvement in vision, both uncorrected and best corrected vision. We often see improvement in contact lens tolerance. And so the answer to this, if this is a question, would be all of the above. It really helps in all these things for most patients. Now, crosslinking was first developed by Theo Seiler in 1998, and he really came up with this great idea that really has made such an impact in so many people's lives. And he developed the Dresden technique, which is anesthetic drops are placed on the eye, the corneal epithelium is removed, riboflavin drops are placed on for 30 minutes, followed by 30 minutes of UV light at 3 milliwatts, and then a bandaged contact lens is placed and the eye heals like a PRK patient. So this is a very straightforward technique, and it has proven to be very successful as a basic step or a basic technique for crosslink, although there's more advanced techniques nowadays. Now, one of the big challenges is understanding what happens after crosslinking with epi-off. And so here's just a question. After epi-off crosslinking, 1 month later, do you expect corneas to become steeper and thicker, steeper but thinner, flatter and thicker, or flatter and thinner? And this is one of the challenges that people don't realize is that in patients who have keratoconus, the epithelium is often thinner over the cone. And so when you remove the epithelium grows back thicker, so the cornea can actually be steeper, although there is some compaction with the crosslinking procedure, so it becomes thinner. So the answer is actually number 2. And you can see this is a nice little map by Ray Stein, who just helped to show that pre-op, the epithelium, which is yellow, is relatively thin and very close to the orange, which is the apex of the stroma. And then when it grows back, it actually grows back a little bit steeper at first, and so the epithelium is actually steeper at first, and the whole cornea is steeper at 1 month. But then that eventually thins out over time and gets back to normal over the course of a year. So even at 6 months to a year, you'll see flattening with epi-off crosslinking, but it's not immediate. Now this just changes over time of epi-off crosslinking, and you can see that at 6 months you get some flattening, at 1 year there's more flattening, and at 3 years there's more flattening than at 1 year. And this is something that we typically see at our center as well. So the epi-off crosslinking is a very nice technology, but there are some risks. You can get delays in epithelial healing. You can get, since you have an epithelial defect, there's a risk of a corneal ulcer. You can also get corneal haze. Rarely you can get endothelial cell damage or decompensation. So this is very rare, but those are all the last one can happen. So all those things, delays in epithelial healing, corneal ulcers, and haze are potential risks with epi-off crosslinking because we're removing the epithelium. Now, epi-on can be as effective as epi-off, and so we've been using that in our clinical trial for the last 5 years plus. And so we find it's just as effective in our hands at stopping progression of keratoconus, but also helps improve the corneal shape in many patients. And thankfully, the risks of infections, delays in healing, or corneal haze are very rare with epi-on. And with both procedures, since there's about a 2 to 4% typically risk of progression or needing a second treatment, they both can be repeated safely. Now we've been performing transepithelial crosslinking for over 5 years as part of a clinical trial, and we use a very simple technique, and this is one that most people can adopt, which is using riboflavin 0.1% with gum cellulose every 2 minutes. This type of formulation is available at most compounding pharmacies, and you can get that from your local compounding pharmacy and as part of a clinical trial now, but eventually once there's approval, and help treat your patients. Let me go back here for 1 second. After you place the drops, we find that it helps if you also at the same time place a corneal protector sponge on the cornea and then place drops of riboflavin directly onto the corneal sponge and alternate that with topical tetracaine with BAK every 2 to 5 minutes. And loading typically takes, with this formulation, about 60 minutes, sometimes even 80 minutes. There are some formulations that can speed the time of loading, riboflavin loading, but overall, your technicians will place the drops for about an hour with this type of technique or this type of formulation, and then over time it can be plenty of riboflavin in the cornea. We want to assess the riboflavin in the cornea. We do this by looking in the slit lamp with a cobalt blue filter, and that's on the right. You can see one of my patients. You can see that there's very bright fluorescence, but if you look down at the very bottom, there's dark blue. That's an area where there's no riboflavin. That was near the limbus, and we didn't need to get riboflavin there. The other picture on the left is from Dr. Rubenfeld, which is just a regular white light showing that the corneal stroma has turned uniformly green, showing that the riboflavin has saturated through the stroma. Now here's an example where there's not enough riboflavin present. So this patient had used a sponge, but for some reason this little area, this dark blue area, did not really load well. You can see that also in the slit lamp cross section. So this patient should not be treated with UV light at this point. They need additional riboflavin loading before advancing to UV light use. So with all that in mind, we're talking about how older patients and younger patients can progress and the fact that cross-linking is a treatment to not just stop progression but also to improve corneal shape. I had a patient who was 68 years old with a mild cataract who came to me and wondering whether cross-linking could potentially help his condition. And when you look at complication rates, this is a paper from Dr. Seiler, Kohler and Seiler, that the progression rate with epi-off cross-linking in their paper was about 7.6%. I think that's a little high. I think the average is about 2 to 4%, with more other studies I've looked at with epi-off. It should be a similar rate with epi-on. Our numbers are trending a little bit lower, but I guess as patients come back for follow-up, I guess it should be in that 2 to 4% rate. And the other thing, though, is what is the risk of complications? And the risk of complications, where you get 2 or more lines of loss of vision with epi-off cross-linking, that occurred in almost 3%. And the major risks were age older than 35 and starting off with pre-op corrected visual acuity of 20/25 or better. So that makes sense. If you start off with 20/20 vision and have epi-off cross-linking and you get haze or a problem, then there's an increase that could certainly lead to a loss of best corrected visual acuity. Again, older patients, you're taking off their epithelium and they can have an increased risk for a complication. So the nice thing for these older patients, we could offer them epi-on cross-linking. And there's just another study just showing that the rate of needing a second procedure was 3.17%, which I think is appropriate this is for the epi-off. So here's this patient, 68-year-old male. This is the other eye, but both eyes underwent treatment. You can see that there's significant inferior steepening present, and the Kmax is 50.6. And then 18 months later, the patient came back, and you can see here that over those 18 months, the Kmax flattened from 50.6 to 45.9. But more importantly, you can see that that right where the pupil is, that there's significant improvement in the corneal shape. So that was really nice. The patient experienced some improved vision, although the cataract was advancing. And what's interesting always with these patients, if you look at it over further time, you can get further improvement. So here's a patient now at 3 years with even further improvement of their disease. So, well, you might wonder, well, why would you cross-link a 68-year-old male? They're probably stable, although it's possible they wouldn't be stable. The reason is that not always, but many times you get improvement in corneal shape like this, which could really lead to improvement in their visual functioning. So it really can make a difference, and that's what we talked about, and this patient was very pleased with the result. Now, we are part of a clinical trial called CXL USA. We can provide both epi-on and epi-off, and we treat patients with keratoconus, foreign fruits keratoconus, pellucid marginal degeneration, and post-LASIK ectasia. You see we have multiple sites around the United States, and it is part of a clinical trial with IRB oversight. And this is some data from our clinical trial, and you can see that this is changing Kmax over time from my center, and looking at 3 months, 6 months, 1 year, and 2 years. And patients with steep corneas, you can see there's significant flattening over this time period. And you can see the average age is 34.5, but you can see some nice flattening, and again, from 1 year to 2 years, you can see further flattening over time. Now, let's look at some case examples. This is a 35-year-old female with keratoconus who I did epi on crosslinking in 2012, and I came back in January 2015 with a 5.8 diopters of flattening. And you can see that it's the central flattening in this situation, where in the difference map, which is the far right area, you can see all the blue, and that's all the flattening. So I was able to use the difference map to not only point out that there's a significant drop in the Kmax, but you can see the whole cornea has gotten flatter symmetrically. Here's a 56-year-old male, again, a little older patient. You can see preoperatively, best corrected visual acuity is 20/25. The patient did not have a cataract, and we talked about the benefits of improving the quality of vision, because the patient did report ghosting around images, and you can see that over this time period, which was 6 months later, you see that there is significant flattening in the difference map, and the patient's best corrected visual acuity improved from 20/25 to 20/20, and the level of myopia dropped significantly. The patient is very pleased overall with the result. When they go to get when that patient goes to get cataract surgery in the future, they'll have a much better corneal shape, and they'll have a much improved result. Here's a 21-year-old male who unfortunately developed post-astigmatism at an early age. You can see that 3 months after surgery, you can often see these rapid improvements. You can see that this change in the refraction, the patient's uncorrected visual acuity was still the same, but the best corrected visual acuity changed and improved. And you can see this difference map really shows us the tail of what happened. There's flattening below, and then above there's some steepening. And so even though there's only a 0.5 diopter shift in the Kmax, the patient was really pleased with the quality of their vision improvement because of the relative reshaping of the cornea with crosslinking. Here's just one more patient, epi on crosslinking for ectasia. The patient has a pellucid pattern, 38 years old, but the uncorrected visual acuity improved in just 3 months from 2200 to 2050. The refraction improved, and the best corrected visual acuity improved. And I thought it was interesting. This is where you can see there's a reshaping of the cornea, and in a pellucid pattern below, you can see the blue, which is where it flattened, in the right map, but there's also some corresponding steepening above, so the whole cornea is reshaping, explaining why there's improvement in both the uncorrected and best corrected visual acuity and the refraction. All right, so here's another patient. Sorry, I hope that everyone's enjoying all these patients who had epi on crosslinking, and this is their 2-year visit. You can see that the patient improved from 55.8 to 53, changed from 55.8 to 53.5. So it was a flattening of 2.3 diopters. However, the best corrected visual acuity went from 20/25 plus 2 to 20/40. You can see that there's significantly more astigmatism present at this 2-year visit. Now, it's interesting. The Kmax got better, but the vision got a little bit worse. And the reason it got worse is it can be seen in the difference map, where the astigmatism just increased significantly. And you can see that red line going axis is, maybe in the 150 range, but there's significant shifting of the amount of astigmatism, leading to difference in the refraction and loss of best corrected visual acuity. Now, in this case, we talked about their condition, and we said, okay, what can we do? Even though things have gotten flatter in general, the patient was actually seeing a little bit worse. And so my recommendation was that we repeat the treatments. So this is 3 months later. The patient went from 2040 back to 2025. The Kmax further improved from 53.5 to 52.2. And now comparison, you can see that there's further flattening, but now we have generalized flattening. And the patient's, although the patient still had significant corneal astigmatism on refraction, overall the patient had some improvement in the best corrected visual acuity, and it feels like we were making some progress. And just to compare the difference, that's just showing one spot, which is 1.5 diopters flatter from the 2-year post-op visit where we did the repeat treatment to the 2 years and 3-month visit. Now, just comparing the patient from the very beginning to having both treatments, the patient started off at 20/25 plus 2, Patients still not quite as good as they were as far as their best corrected visual acuity, their 20/25 -1, but the Kmax had improved by a significant amount. They're definitely not progressing. They just still have a good amount of astigmatism, which hopefully will continue to improve over time. Now I'll share one additional patient. This is a very important VIP patient of mine at age 9. Had relatively normal corneal topography. As a father, and I decided to evaluate my child, and you can see the topography is normal, but the patient came back at 12 years and 9 months. This is my family member, and she has, you can see my daughter, and you can see she has significant inferior steepening in both eyes, consistent with early keratoconus. There's no family history. She had just developed myopia and then some astigmatism, and we got the topography, or this time the Pentacam. You can see this inferior steepening. So we decided to offer cross-linking, and she did very, very well. This is her 3-month visit. You can see that her best corrected visual acuity remained at 20/20. She had some slight improvement in her right eye from a corrected visual acuity of 20/80 to 20/60. And you can see she had significant flattening below, and you can see like the Kmax. There's one area of keratometry reading went from 45.9 to 45.0, so 0.9 difference below. And then her left eye, same type of improvement, 2100 to 2080. And you can see that she had about a 1.1 diopter flattening below, and just early on she was experiencing an improvement in her condition. When she came back at 18 months, you can see that she had even further improvement. Her uncorrected visual acuity improved from 20/80 to 20/50 +2, and her best spectacle corrected visual acuity remained stable. But you can see that she's having a significant inferior steepening below, or flattening. So flattening below and some steepening above, so reshaping the cornea, just explaining why she's achieving improved quality of vision. Same with her other eye, same thing. She's getting nice flattening below and some steepening above, and very happy with her improved quality of vision overall. So in summary, I hope this is a very helpful overview of corneal collagen cross-linking and how we can use technologies such as Pentacam to evaluate our patients before and afterwards, as well as evaluate patients for progression who have keratoconus. I hope for my lecture I was able to help show you that that both epi-on and epi-off are effective treatments for improving corneal shape, and more than just stopping progression of keratoconus, but they actually improve corneal shape. And they're epi-on is a very safe procedure overall. And I showed you an example where we could retreat patients with epi-on, and with both treatments you could really retreat patients if needed, and that would occur in about 3% of your patients. Again, we talked about the keys to transepithelial cross-linking, and I think the pros overall is that it's effective for stopping progression of keratoconus, post-LASIK ectasia, and pellucid marginal degeneration. We can expect improvement in many patients of corneal shape and help improve best corrected visual acuity. When a progression occurs with epi-off or epi-on, repeat procedures can safely be performed, and you can stay with the same modality. So if you're an epi-off surgeon, you can just repeat epi-off, and if you're epi-on, just repeat epi-on. And I'm hoping that you understand, and at least I can share the data, that epi-on can be as effective as epi-off at stopping progression. And we often see this improvement in vision with epi-on, so it is a very reasonable treatment for your patients with keratoconus, pellucid marginal degeneration, and post-LASIK ectasia. So with that, I'm happy to answer any questions, and thank you so much.
Thank you, Dr. Trattler. Thank you for being here, and also for that very interesting and informative presentation. You definitely gave us some clinical pearls for those out there that are new to cross-linking, as well as those that are experienced, I think. Also, I think you dispelled some of the misconceptions out there about cross-linking. Ladies and gentlemen, if you would like to see a recording of this webinar in the future, we will have it posted to our website at oculususa.com under Oculus Webcasts. Also, if you are interested in signing up for future Oculus webinars, you can go to the same place, that's oculususa.com, and click on the link that says Oculus Webcasts. If you have any questions about tonight's webinar or any other webinars, you're also welcome to email us at sales@oculususa.com. So thank you again, Dr. Trattler.
Thank you as well. My pleasure.
And I'd like to wish everybody a good evening.